purpose of this morning's session is to meet with officials from the Department of Health, the HSE and the Health Products Regulatory Authority in relation to the implications for the health sector of the decision of the United Kingdom to withdraw from the European Union. On behalf of the committee, I would like to welcome Mr Jim Breslin, Secretary-General of the Department, Mr Fergal Goodman and Mr Kieran Smith of the Department of Health, Mr John Hennessy and John Swords and Mr Paul Keown of the HSE, and Dr Lorraine Nolan, Chief Executive of the, Rita Purcell and Katrina Fisher of the Health Products Regulatory Authority. Sorry for overlooking you. Oh, upset. Excuse me, gender problem. I wish to draw your attention to the fact that by virtue of Section 17(2)(l) of the Defamation Act 2009, witnesses are protected by absolute privilege in relation to the evidence to this committee. However, if you are directed by the committee to cease giving evidence in relation to a particular matter and you continue to do so, you are entitled thereafter only to qualified privilege in respect of your evidence. If you are directed that only evidence connected with the subject matter of these proceedings is to be given, and you are asked to respect the parliamentary practice to the effect that, where possible, you should not criticise or make charges against any person or persons or entity by name or in such a way as to make him or her identifiable. I also wish to advise you that any opening statements you have made to the committee may be published on the committee's website after this meeting. Members are reminded of the long-standing parliamentary practice to the effect that they should not comment on or criticise or make charges against a person outside of the Houses or an official either by name or in such a way as to make him or her identifiable. Can I now ask Mr Breslin to make his opening statement? Thank you.
Thank you, Chairman. I'd like to thank the committee for inviting the Department of Health to engage with you in relation to the preparedness of the health sector for Brexit. You've just introduced the witnesses, Chair, so I won't repeat that. At the outset, I wish to assure the committee that detailed planning for Brexit has been ongoing in the Department and its agencies for over 2 years. As part of the whole of government work on Brexit preparation, the Government is working to secure an orderly and agreed Brexit. But in view of the uncertainty in London and the increased risks of a no-deal Brexit, we will continue to intensify our preparations for any such outcome. Our number one protection from whatever Brexit brings will be our status as an EU member state, with all the stability, predictability and solidarity that brings. On the 19th of December, the Government published its Contingency Action Plan, which outlines the approach to a no-deal Brexit planning, and the Department of Health and its agencies are contributing in full to this. Brexit of any kind will mean change and will impact on all sectors, including health. It is recognised that managing a no-deal Brexit would be an exercise in damage limitation, and it would be impossible in a no-deal scenario to maintain the current seamless arrangements between the EU and UK across a full range of sectors, which are currently facilitated by our common EU membership. Notwithstanding that, it is important to underline that certain measures will allow us to mitigate as far as possible the implications of a no-deal Brexit. Both the Irish and British governments are committed to maintaining the common travel area in all circumstances and have committed to undertaking all the work necessary, including through legislative provision, to ensure that the common travel area rights and privileges are protected. The Department has focused attention on protecting the common travel area in terms of access to healthcare and allowing the free movement we currently have for Irish and UK citizens. Protecting and maintaining the common travel area and the associated rights and privileges is a key part of our contingency planning and preparations. This is vital in the context of the Good Friday Agreement and the Northern Ireland peace process, as well as broader UK-Ireland relations. The Department continues to work closely with other government departments and agencies on all aspects of Brexit planning, particularly the Department of Taoiseach and the Department of Foreign Affairs and Trade. The Department is represented at all cross-sectoral working groups and is cooperating fully with colleagues across government. The Department has also strengthened its internal capacity to plan for Brexit. I meet with the heads of the HSE, the Health Products Regulatory Authority and the Food Safety of Ireland weekly to review progress on Brexit preparedness and to consider any new challenges identified. I have also established a Brexit operations team chaired by a Deputy Secretary-General in the Department and comprised of senior officials from the Department, HSE, HPRA and the FSAI. This group works to resolve issues and to escalate them to the heads of agency group, which I chair, if necessary. An interagency communications group chaired by my department has been established to plan for all aspects of a communication strategy, to ensure that the public is fully informed of the health implications of either a central case Brexit or a no-deal Brexit. A further working group is working to identify and monitor medicines that may be vulnerable to supply disruption as a result of Brexit. The Department and its agencies, particularly the HPRA, FSAI and HSE, have been in regular contact with stakeholders to assess the level of preparedness for a no-deal Brexit. It is important to state that while the Department continues to monitor and seek assurances in a number of areas, our current analysis is that there are no immediate risks to the health of the population because of Brexit. It is important also to note that cooperation on healthcare provision and the protection of public health on the island of Ireland and between Ireland and Britain has developed over many years to the mutual benefit of all parties. Some of these arrangements are underpinned by EU regulations, while others are on the basis of bilateral agreements or service-to-service arrangements. Both governments have repeatedly stressed that they are anxious for these services to continue post-Brexit, and the Department of Health continue to be in close contact to facilitate this. I would like now to update you on the progress and current status of priority issues since the Department's last appearance on this subject at the Committee in January of last year. In the event that the United Kingdom leaves the European Union on the 29th of March 2019 without a withdrawal agreement in place, it will be necessary to put in place legislative provisions to enable necessary healthcare arrangements, including reimbursement arrangements, to be maintained between Ireland and the United Kingdom. The Irish and British governments have committed to maintaining the common travel area and its associated rights and privileges. These arrangements facilitate access to health services in the UK and Ireland, including access to emergency, routine and planned healthcare. The draft heads of the proposed legislation, therefore, seek to put in place an appropriate legal framework in Ireland to ensure the continuation of the common travel area arrangements. The Department, as part of the cross-government approach to contingency planning, has prepared heads of a bill which is consistent with our commitment to provide for these rights and privileges. The proposed legislation would allow the Minister for Health and the HSE, as appropriate, to cover the costs of healthcare provided in the UK under the same conditions as currently. For example, where treatments are not provided under our own healthcare system, or for an Irish person who becomes ill while on a visit to the UK and needs immediate healthcare there. It also makes provision to preserve existing eligibility for healthcare in Ireland for a range of different cohorts of people, including, for example, UK pensioners residing in Ireland, frontier workers and for UK residents on a temporary visit here. As part of our common travel area discussions, key principles have been agreed at official level with the UK to maintain bilateral health cooperation. There has been very good ongoing engagement with the UK on the technical work needed to ensure continuity of arrangements. Proposals are now being examined with a view to ensuring the maintenance of the status quo, pending the finalisation of longer-term arrangements. This cooperation will support the objectives of the healthcare legislation proposed in the no-deal Brexit Omnibus Bill. It is also important to state that this overall framework will build upon many years of very positive cooperation between the two jurisdictions. This is true of our administrative systems, but is also true at a clinical level. There are very strong and well-established relationships at clinician-to-clinician level. Indeed, many of our respective clinicians have trained together. In all of our preparations, we have been able to build upon this very strong spirit of collaboration in the interests of patient care at clinical, hospital, administrative and political levels. In relation to the supply of medicines, the Department is working closely with the HPRA and the HSE. Since the UK referendum, industry has undertaken very significant work in modifying supply chains and revising regulatory pathways to guard against Brexit. This work is continuous, and the Department, the HPRA and the HSE are continuing to work closely with suppliers. As part of a whole-of-government response to Brexit, Minister Harris recently outlined a comprehensive set of preparations to ensure continuity of health services and supply of medical products in the event of a no-deal Brexit. This work involves the Department, the HSE, the HPRA and other agencies engaging in intensive Brexit preparedness and contingency planning. In relation to the supply of medicines and other goods, significant work has been taken together with the pharmaceutical industry to anticipate, insofar as is possible, potential vulnerabilities. risk assess these and devise contingencies in order to minimise and address any risk to continuity of supply of medicines. No major supply issues have been identified through the preparedness and contingency planning exercise. Ireland is unlikely to face serious general medicine supply issues in the period immediately after 29th of March. Any emerging supply issues will, in the first instance, be dealt with from existing supplies held within the domestic distribution chain. It is important to reiterate there are already additional stocks of medicines routinely built into the Irish medicine supply chain. This is different to the wholesaling model which operates in the UK. The pharmaceutical industry and wholesalers have provided assurance that they are confident that they will have sufficient stocks to bridge any initial issues at ports should they occur. There is no need for hospitals, pharmacists or patients to order extra quantities of medicines or for doctors to issue additional prescriptions, as doing so could disrupt existing stock levels and hamper the supply of medicines to other patients. As an additional safeguard, special consideration is being given to those categories of medicines which are considered most essential to public health. An expert group is examining these categories of medicine, and where the supply chain indicates that Brexit could potentially cause issues, are working with suppliers to verify that robust contingencies are in place. Work on this process is ongoing and will continue for the foreseeable future. Both the HPRA and the HSE have requested that companies highlight any issues regarding the availability of specific products associated with Brexit. No major issues have been identified to date. If any potential issue is identified, it will be managed through the existing medicine shortages framework. Medicine shortages inevitably arise from time to time and are a feature of health systems around the world. The HPRA has an existing medicine shortage framework in place to help prevent shortages from occurring and to reduce the impact of shortages on patients and healthcare professionals by coordinating the management of potential or actual shortages as they arise. This framework is already used to manage and address an average of 45 shortage notifications a month. There is no current shortage caused by Brexit. In relation to the recognition of qualifications, the mutual recognition of qualifications has been considered in the context of the negotiations on the withdrawal agreement and the framework for future relationship. Clearly, the EU-UK agreement on the mutual recognition of qualifications, were it to be achieved, would address the issue in the best way possible. The recognition of qualifications has been discussed as part of the engagement at official level between the UK and Ireland on the common travel area. Both the UK and Ireland are committed to ensuring measures are in place to allow for the recognition of qualifications within the parameters applying. The UK has recently published draft regulations which is intended to enact in the case of a no-deal Brexit. This legislation will enable Irish qualifications to be recognised in the UK. The Irish health professional regulation bodies have been examining the mechanisms in place for the recognition of qualifications with the objective of ensuring efficient processes for recognition for those holding UK qualifications, while ensuring this is done in an objective and non-discriminatory way. The Irish bodies have been linking with their UK counterparts on this issue. In relation to food controls, the maintenance of food safety standards of food imports from the UK and the efficient flow of food through the ports is another issue which the Department is planning for. The withdrawal of the UK from the EU and its new status as a third country will have implications for the official food control system in Ireland. The Food Safety Authority of Ireland is the central competent authority for official food controls, controls which are carried out by a range of official agencies. This includes the HSE's Environmental Health Service, which is largely responsible for foods of non-animal origin, and the Department of Agriculture, Food and the Marine, which is responsible for foods of animal origin and plants. Challenges ahead in this area include import and export issues, as well as potential divergence with EU law over the longer term. The importation of food is subject to EU legislation. Additional resources have been provided to conduct the appropriate checks where Ireland is the first point of entry to the EU. Preparations are also underway in the event that the UK should decide to require export certificates for certain food products. To facilitate these preparations, the Department is working closely with the relevant agencies and has approved additional resources for Environmental Health Service staff, the Public Analyst Laboratory and the Food Safety Authority of Ireland. It is also working with the Environmental Health Service, the Department of Agriculture, the Revenue Commissioners and the OPW with regard to the infrastructure and traffic management requirements at Dublin Port, Dublin Airport and Rosslare Europort. The aim is to ensure that the appropriate food controls are conducted from a public health perspective while being cognisant of the implications on trade. In conclusion, I wish to reiterate that the Department, Minister Harris and the relevant agencies under the aegis of the Department are fully engaged in Brexit planning to ensure as far as possible that the health sector is prepared for any adverse impacts as a result of Brexit. We recognise the valuable work of the committee and I thank members for the opportunity to be here today and I look forward to your views and questions.
Thank you very much, Mr. President. And now can I call on Mr. John Hennessy to make your opening statement. Thank you.
Good morning, Chairman. The invitation to this meeting to discuss Brexit preparations. As mentioned earlier, I am joined by my colleagues John Swords, National Director, HSE for Procurement, and Ms Paula Keown, Assistant National Director for the HSE's North-South Unit. The HSE has been preparing for some time for Brexit on the basis of a central case scenario and obviously for a potential worst case scenario also, while at all times aware that negotiations are ongoing to help ensure that the necessary transition arrangements are in place in order to maintain continuity of health services. The HSE Brexit Planning Group has been in place since 2017 and has been working closely with our department colleagues on a wide range of Brexit contingency planning and mitigation actions. The focus of this work has been on Brexit implications across the following key work streams, and they include continuity of patient and client health services, cross-border and frontier arrangements including COUT, emergency health care including the ambulance service, public health matters, environmental health, workforce issues and recognition of qualifications, and continuity of supply of goods and services including procurement. In relation to continuity of patient care, the focus of the mitigation measures here is on ensuring that service level agreements and memoranda of understanding are in place where they are necessary. And this applies to specific service areas such as emergency cross-border arrangements, including cardiac and cancer care services, treatment abroad placements, cooperation and working together arrangements, and obviously the EU North-South Unit is working to ensure that services currently available to people living in border areas continue to be available post-Brexit. Examples of those, as I mentioned, include those cardiology and radiotherapy services at Altnagelvin, specialist cardiac services provided on an all-island basis for children at Our Lady's Hospital in Crumlin. Arrangements in relation to other specific areas of healthcare, such as paediatric organ transplant services, for example, are progressing, and agreements are being finalised with the relevant UK hospitals to ensure continuity of service post-Brexit, and that includes Great Ormond Street Children's Hospital. In the area of emergency services, the National Ambulance Services here and in Northern Ireland are liaising closely to ensure service continuity and agreement in regard to operating procedures. There are two key MOUs in place between the respective ambulance services. Firstly, the Memorandum of Understanding on the provision of assistance in the management and resourcing of emergency and urgent calls, and secondly, the MOU covering mutual aid for declared major incidents. And these join both jurisdictions in their response to those emergency situations. The Environmental Health Services engage in ongoing discussions with both Departments of Health and Agriculture in relation to import and export of foodstuffs and to the possible divergence of food regulations and controls over time. Additional resources, as Jim has mentioned, have been made available in 2019 to strengthen the EHO service capacity in this regard, and those additional posts are being recruited at present. The wider workforce implications of Brexit have been examined in detail by the HSE's HR department, and key risks in this area, such as mutual recognition of qualifications and training of professional staff, have been analysed in detail in the context of the movement of healthcare workers. And the HSE is again liaising closely with the respective professional bodies and the regulators with a view to facilitating the continuation of existing recognition arrangements. With regard to goods and services and examples of medical and surgical supplies, medicines, the key risks in the short term here relate to potential disruption and delay to supply chains. Jim mentioned earlier, a joint group has been a working group between the HSE department and HPRA have been engaged in intensive work in this area, which involves identification of suppliers of critical medicines and detailed follow-up in relation to specific product lines. Key supply chain challenges in the short term are likely to be related to medicines with short shelf life, those reliant on refrigerated supply chains, some compounded products, and time-critical logistics. That joint HSE-HPRA group is liaising closely with hospitals and community pharmacists to identify short, medium and longer-term concerns regarding the continued supply of drugs and any risk to such supply and the proposed mitigation of those risks. This work is being done in close collaboration with the pharmaceutical industry and both hospital and community pharmacy stakeholders. Just a quick mention regarding vaccines. We currently have a 2-month stock held in the HSE's cold chain service, and along with stock held by supplier companies in Ireland, it gives us approximately 6 months supply on the island to ensure continuity of service delivery. I'm joined by my colleague Mr. Swords here, who can provide further detail in relation to goods and services post-Brexit. In terms of next steps, the HSE is continuing to work closely with service providers, with suppliers, patient groups in relation to Brexit preparations. This involves identifying, assessing and addressing the necessary contingency measures and actions required to maintain service continuity in the event of both an orderly and a potential disorderly Brexit. The HSE is also continuing to work on awareness of Brexit implications among HSE and health service staff generally, and along with our colleagues in HPRA, Food Safety Authority and key suppliers, and with patients and the public in consultation with the Department of Health. That concludes my opening statement, Chairman, and together with colleagues we will endeavour to answer any questions you may have.
Thank you very much, Mr. Hennessy. Could I start proceedings then by asking just to expand on the treatment abroad scheme and the cross-border directive, both of which are very commonly used by Irish patients seeking treatment abroad. And of course they involve reimbursement of payments for those services. So could you just speak about how they will continue, or will they be affected in any way?
Yeah, so and I might ask my colleague Fergal Goodman to come in on this too. I know we've supplied to the committee previously the activity under those schemes, and I think it is notable that whereas we have as EU citizens entitlement to travel for treatment abroad or the cross-border directive right across the EU, the majority of people are accessing care in the UK or in Northern Ireland under both of those schemes. The treatment abroad, because that's where, and I refer to it in my statement, our specialist links are most developed. So John has mentioned Great Ormond Street. We have a range of institutions in the UK that we're very connected to. That will continue post-Brexit. We're confident about that for 2 reasons. One, the level of engagement that John has talked about with those institutions says that they completely understand the patient rationale here. And in fact, it's to their advantage that we form part of, if you like, the catchment area for that very highly specialist care, that we are able to feed in our patient to give them a critical mass of treatment within these islands. If they were to lose some of that critical mass, it would actually undermine their services. So not only for altruistic reasons, which are very important, but also for the reputation of their units, they want to continue that relationship with us. And that is the very positive message that we've gotten in our interactions with those facilities. The bill, which is the heads of bill which have been published, will give us the legal authority, subject to the drafting and making its way through the House, to reimburse those facilities for the care that they give. At the moment, that's done through a completely EU-wide process where there's low administrative overhead and there's pretty well-established rules as to how that will happen. In a post-Brexit situation, the UK will no longer be part of the treatment abroad scheme, EU-defined, but we will have an equivalent arrangement with the UK, and we will reimburse them, as we currently do through the EU, but we will reimburse them directly for the care that they give. In respect of the cross-border directive, the legislation also has an enabling provision which would allow the Minister and the HSE to meet costs of the travel of Irish citizens to access treatment on an equivalent basis to the cross-border directive. So currently, if somebody goes to an EU member state, pays for the cross-border care, they can come back to the HSE and have that reimbursed. We would seek to put in place a similar scheme. It won't be the EU cross-border directive scheme, but a similar scheme that would allow Irish citizens to continue to travel to Northern Ireland or the UK, and the Irish government would reimburse them for that. The UK authorities have indicated to us that they would be interested and that they would be prepared to facilitate continuing access under those arrangements. So that's where we are in relation to both of those. Fergal may wish to expand on it.
Just on that point, Mr. President, can Ireland enter into bilateral arrangements like that with the UK, or would it have to go through the EU to do that? So
part of the rationale here is the common travel area, which says that we are completely fluid in how people move around and labour moves around, and that we have such historic links between us in relation to that we have to put an overarching set of entitlements. There's no point in saying to somebody, you have a historic right to work in another country, if when they work there and they need healthcare, you say, oh, we haven't covered you for that. So the common travel area has always covered for not just people's ability to work, but also the social security that goes around with that, and it will be through those mechanisms that we will seek to do that. The cross-border directive is probably the bit that's an extra bit, but we have signalled in the Heads of Bill our intention that we would like to provide for that. We will have to work that through with the Oireachtas as the legislation goes through the House.
Thank you. Mr. Goodman, were you good? Thank you.
Not a lot to add, really, but I suppose the principal distinction between those two schemes is that the treatment abroad, as Secretary-General says, is very much a service-to-service arrangement, and the HSE have, as Mr Hennessy has indicated, are proceeding on the basis that those service-to-service arrangements, they're very essential in many ways and need to be maintained almost whatever happens. The legal enabling, or let's say confirmation of the HSE's legal authority to continue with those arrangements is one of the purposes of the bill. The cross-border directive, I suppose, as people will be aware, is more of a, it puts under the directive, it puts the control, if you like, in the hands of the patient to elect to source a service elsewhere, and that, I suppose, is something that would not otherwise exist in legislation. So that, I think, is something that particularly the omnibus bill, which is being developed, will need to pin down. But again, as Secretary General has said, what we're seeking to have is the legal underpinnings that will enable the patients to continue to make those kind of individual choices to access services. That's the policy mandate that government has given us in that regard, and has indicated both arrangements are essentially dependent on reciprocation from the UK as far as is necessary to enable those systems to operate. As of the moment, our understanding is that we expect that reciprocity to be forthcoming, all other things being equal.
Thank you very much. So, Deputy Donnelly.
Back to me, Chair.
Yes,
okay, yeah.
certainly. Senator Burke.
Yeah, just thank you very much for your presentation, and indeed for all the work that has been done by both the Department and the HSE. I think everyone very much appreciates it. And indeed, you know, on the whole cross-border directive and the work done over a long number of years on that, I think both the Department and the HSE played a major part in that being developed, and as a result, Irish people have benefited substantially from you know, where treatment in particular isn't available here in Ireland, that people can travel abroad. I suppose one of the questions that I want to ask, from your presentation, it would appear that you're saying you've covered, I suppose, an awful lot of the angles. I'm just wondering, is there a particular angle that you're concerned about that will now change? And the one area that I want to find out about is, for instance, if I'm abroad and I'm working, say, in the UK, and I end up having healthcare, and say I do have private health insurance, have the private health insurance companies engaged in the same way as you have? as regards making sure the arrangements that were there before will also be the arrangements there after the 29th of March. And I'm just wondering, have you had any feedback from the health insurance companies on that? And the other one then is about, I suppose, between Northern Ireland and between Belfast and Dublin and Derry and Donegal. You know, there's been a huge amount of work done there as regards joint cooperation on the providing medical care for people from Northern Ireland coming down south and people from the south going up to hospitals there. Will there be any real change in what's available and services that will be available to people, and what will there be a change even, for instance, in relation to how the remuneration is then resolved between the parties? I'm just wondering what kind of changes do we expect in that whole area. And I suppose the other issue is in relation to training in relation to medical care. One of the issues that has changed quite a lot in Ireland is the whole working time directive. And on the one hand, you know, it has been very good for staff as regards working time and the hours that they put in every week. But some other people would claim that as a result of the reduced working hours, there's less training. And now that the UK is going to be outside of the European Union, the likelihood is that they will change some aspects of the working time directive. And I'm just wondering, how are we going to deal with that, in the sense of, you know, we have certain specifications about the qualifying criteria. Will that change now as well, or has there been any indication that there will be changes in that area in relation to training, whether it's nurses, whether it's pharmacists, whether it's physiotherapists, or whether it's general practitioners or doctors? And I'm just wondering if there has been any discussion on that whole area.
No, thank you very much for the question. I'll ask people to come in as we go through them. But actually, the question, it's very helpful. The question of what might change, and people may not have seen it. I've seen a headline in the Times of London which has picked up on my opening statement and has summarised, I don't think accurately, the position of my opening statement, which was medicines will be fine, but cross-border services will be impacted. And that's not what I said in my opening statement. So I'm very happy to say that in response to the question, we don't expect the North-South arrangements to be affected by Brexit. That is not the base on which either jurisdiction is planning. When I referred in my opening statement to the general proposition that Brexit is going to change our life and it's going to have implications for all sectors, it wasn't the North-South arrangements or the cross-border arrangements that we currently operate that I was thinking about, and I can give maybe examples of what I was thinking about. In relation to the North-South, we have really strong relationships. We've provided capital for the opening of the radiotherapy unit in Oireachtas. We were there at the design stage, and we've been there at the commissioning stage, and we pay for the service that we get, as we do for the primary cardiac catheterisation in Oireachtas, and as we do for some other services in the north. And equally, our colleagues in the north are providing for the capital development in relation to Crumlin, so that children from the north with congenital heart defects can be treated in Crumlin, and they will pay the revenue costs for that. So this is very much founded on the patient outcomes that can be produced through working together, and we were very confident that they will be sustained through this period of disruption. Because those arrangements are largely, and John can come in and expand on it, are largely governed by service level agreements, where, as I say, we've in some cases contributed to the capital costs, and in lots of situations we're meeting the revenue costs. They don't actually currently go up to Brussels and back down to the other jurisdiction. They go directly from the HSE to the facilities in Oireachtas or in other situations elsewhere. So we are confident on those, and John can talk about the detailed engagement that has been happening. In relation to private insurance, so what we've heard back from the health insurers is is reassuring that they are not planning for any impact on those with health coverage. Probably though an important point which maybe didn't come across in the question, I think I'm right in saying, you know, even if you're Irish but you're working in the UK and you're resident in the UK, your health insurance will be written in the UK. The VHI or whoever would write insurance for people who are resident in Ireland. If you're non-resident in Ireland, you would either be getting your insurance in the country you're resident in, or you could get an international health insurance policy. So it's more likely to be in respect of somebody who is resident in Ireland, but in the course of their business, or indeed in the course of their leisure, is out of Ireland and is in the UK, and something happens. And that's something insurers are familiar with. People are in the United States and something happens, and they're familiar with that type. In general, people don't use their insurance to access on a plan basis healthcare in the UK through private insurance, unless it's not available in Ireland, and then there's specific arrangements for it. So I think what we've heard back from the insurers, is that there'll be no change in this area. They have looked at it. In respect to the question about training, a lot of work has happened between our professional regulators. When I talked about in the opening statement that Brexit does change things, this is an example where Brexit does change things. At the moment, if you train in the EU, your qualification is automatically recognised in another EU member state. That's automatic. In fact, nobody can raise an issue about it in the other EU regulator. In this situation, the UK will become a third country. There won't be automatic recognition unless there's an overall deal done between the UK and the EU to recognise qualifications. And there has been discussion in the context of withdrawal and the future relationship on that. But in place of that, we are going to put in place a very low administrative, seamless approach between regulators, regulator to regulator. So our Nursing and Midwifery Board will understand the qualifications in the UK, will have already informed themselves on that, as they currently do, and won't have to go through a long check when they get an application from a nurse trained in the UK, because they will know what the qualifications mean, and they will deal with it within the current timeframes that currently apply. You did ask a very good question, which is what happens if over time the UK diverges? And I don't think that relates to the EU Working Time Directive principally, because the EU could diverge on the Working Time Directive and it mightn't have an implication for the quality of the qualification. But say that the EU diverged, and I'm not talking about the UK if they were to diverge. Obviously Ireland will stay with the EU standards. And I'm not talking about the period immediately ahead, I'm talking about years more than months. But in any of these areas, if the UK decided, and we've no indication that they would, but that they decided to define the qualifications to be a professional in a different way to how the EU does, and they're no longer equivalent, well then that does raise issues for our regulators. We would have to then relook at the situation. Equally in the area of food, if the EU decided if the UK decided we've left the EU, we have the same standards as we have had when we were in the EU, but in 5 or 10 years' time they say, well, actually we're going to change the standards. That is a risk for all of our interactions with the UK if they not only leave the EU, but then they change the standards that they operate under. And that is something that we'll have to watch. As I say, it won't be an issue for 2019, but it is an issue that would have to be looked at and is likely to be one of the issues addressed in the future relationship between the EU and the UK.
Just could I come back in on the training issue? A lot of the guidelines in relation to training here in Ireland are, developed jointly between Ireland and the UK, and I'm particularly talking about junior doctors. And for instance, we have the Working Time Directive here. They may vary from that in the UK, and I'm concerned about separate arguments like you have someone here who's doing 48 hours a week, whereas they vary the Working Time Directive for training in the UK, and it might allow someone to work up to 60, 65 hours a week. I'm just wondering about, long term, where that could affect Irish people who've done 2 or 3 years training here and then going to the UK and then not getting the same recognition. So that's an issue that could arise. And the other issue then is about the exchange of people between Ireland and the UK medical services. A lot of junior doctors would stay here for 2 or 3 years, then go to the UK for another 3 or 4 years, maybe come back after that. It's just, I think it's important that there is that continuation of cooperation and training, because otherwise both countries would suffer. And I'm just wondering that, you know, that would be kept an eye on that issue as well.
No, absolutely. And the second issue is very much at the focus of attention. So not just with doctors, but with nurses, we have quite a range of movement. Yeah. So, for example, the Nurses and Midwifery Act 2011 provides for our Nurses and Midwifery Board of Ireland to enter into agreements with third countries for the purpose of mutual recognition. And effectively that will allow both registration bodies in the 2 jurisdictions to say yes, there's equivalence, and yes, you can move over and back, and we'll allow that to happen in a way that is seamless. And the same for the Medical Council. They may need to change their internal rules somewhat, but given the historic linkages and given the equivalence that we currently enjoy, I think that is something that all regulators on the 2 islands wish to continue with. On the European Working Time Directive, I don't know what the plans of the UK are in relation to this, but I suppose the essential point, which is not to disagree with you, the essential point is not the number of hours, but the quality of the training in the course of those hours. Yeah. So long as we can maintain that our doctors in the 48-hour period are getting the quality of training that would be expected for somebody working a longer length of time in the UK, I actually think it better that our doctors are working the 48 hours and not the 60 hours in terms of performance of duties. But that's where the attention will have to be paid in relation to equivalence.
Mr. Henderson.
Yeah, just briefly add to those comments. I think our HR department have been doing extensive work with the regulators in relation to this and the training issue. And the feedback from that process is not expressing huge concerns in the short term, but obviously the need to monitor any divergence in standards over the longer term, and that's something that will obviously be a priority. And just a brief mention in relation to North-South relationships. My colleague Paula Keown here has been very close to this, and quite a number of joint workshops have been held with colleagues in the health services between North and South with a view to ensuring a seamless transition to the Brexit situation. They have covered specific services like the ones I mentioned in the opening statement, where we have extensive agreements in place. They've been like the cardiac services, the radiotherapy services, the paediatric cardiac services for children. The agreements there have been tested to ensure that they withstand any kind of Brexit situation, and we're satisfied that that is the case. The reimbursement issue and the funding implications come up in terms of issues like cross-border directive, and similarly we've been working on ensuring that a seamless transition can be made there, which maintains current or similar to current reimbursement arrangements, again with a view to a seamless transition and in a way that patients won't be discommoded unduly by it.
Okay. All right. Thank you.
Just in relation to qualification recognition, will it be the Medical Council who will be responsible for qualification recognition?
Absolutely, yeah. And the equivalent for other professions, so the Nurses and Midwifery Board, the CORU and so on. Yeah.
So existing courses, so if a university in England has a particular course for qualification, and then they introduce a new course, say a graduate entry medical school,
yes,
rather than the standard entry,
yes,
will it be the case then that that new course will have to go through new recognition processes?
So I think the first thing would be that the GMC in the UK would have to recognise that new course. And then by virtue of the relationship that would exist between the Medical Council in Ireland and the GMC, where they would understand the GMC's bar in terms of standards, once the GMC had approved that course, the Medical Council here would say, well, actually that meets the GMC's test, and we have looked at what their test is and it's equivalent to ours. So for us, that would be sufficient for us to be able to recognise it.
Okay. Yeah. Deputy O'Mahony.
Thank you, Chair. Welcome in. Jim, you're in again today to us. I suppose when one thinks of Brexit, it's kind of nearly always political or economical consequences. Even myself personally, I suppose it was late in the day when I started thinking of the impact that Brexit may or may not have on our health sector here. So I suppose for the general public, how do you think we can ensure that it is understood what is happening or what could happen with regard to Brexit? Also, the Medical Practitioners Act, you know, that qualifications from Ireland, as you know, must be recognised in other EU countries. So this will be affected, obviously, with regard to recognising qualifications in England. So just your views on that. And Jim, I know you went through there the different things that are set up to discuss the implications of Brexit. But I wonder if you could expand a bit on the work of the Brexit operations team. What do you do when you meet and what do you discuss? Thank you.
Thank you, Deputy O'Mahony.
In terms of the general public and the Minister in briefing Cabinet recently, we have issued public statements on this, and it's also outlined in the contingency action plan. We are also in the process, we've convened stakeholders, particularly around medicine supply, because that is an area where it's very important that there's good, clear public information. And in fact, I'm writing today to stakeholders that we had a very good meeting with last week, which included the pharmaceutical industry, included the IPU, community pharmacists, and a range of other stakeholders, that we are all able to say just exactly what the situation with the medicine supply is. And as set out in my opening statement, it's very important for people to understand that this is a sophisticated industry that has well-developed supply chains, some of the largest multinationals in the world delivering medicines into community pharmacists, working through very well-established, well-resourced wholesalers, and the HPRA, the HSE and the department are working with that industry to preempt any issues. And at the moment, as I've said in my opening statement, we are confident at this stage that there is no issue that's currently present. But medicine shortages is an issue without Brexit, so we will be keeping after this issue. If something were to arise, we will be putting actions in place to resolve that just as quickly as possible. So we are confident at the moment that there is adequate provision and that there's stocks routinely built into the Irish system, so wholesalers hold stocks that are sufficient to bridge any problems that could happen in the ports. And the important message that sends out is that for patients, for retail pharmacists, for hospitals, there is no need to increase stock levels or to ask for extra prescriptions. To do so actually would suck product out of the supply chain, which might produce a shortage and might mean the person who needs it won't be able to get it. So that's a very important public message that we're seeking to promote. We will continue to review this with industry. As John has outlined, we're looking at categories of medicines, we're looking at product lines. So not only are we taking the overall message from industry that they have done the preparations, and we're very appreciative of the work that's happened there, but we are also in the most critical medicines going in and verifying that. So actually saying, in respect of this product, we need that verified. Can you be definitive in relation to how you're going to get the product to us, and that there will be sufficient supply? And again, all of the information to date is that that is ongoing, but it is work that's proceeding, and people are satisfied that they'll be in a position to do that. So I guess that is an important piece of public information that we are promoting. And you know, it would be great if somebody would do something really sensible to conclude an agreement in Westminster that would mean that we don't have to do all this damage limitation, but we are going to do it regardless because of the uncertainty, and we're going to continue to make that information publicly available, and obviously as we get closer to the time we'll make more and more information available. In relation to the other aspect which perhaps would raise public concerns, as I've said earlier, the flow of patients for specialist services services as between Ireland and the UK. We are working for that to continue, and we believe it will continue. We believe that the authorities in the UK are very anxious to facilitate that, and in the individual circumstances which John Hennessy has talked about, whether that's cancer care in Altnagelvin, or it's cardiac care in Altnagelvin, or it's other arrangements that we do, we have that in terms of service agreements concluded, and we're confident that they'll withstand any issues that arise out of Brexit. So I guess in a nutshell, they're probably the two biggest public information messages that I would give today. In terms of the Medical Practitioners Act, as just previously outlined, I think what we will envisage would be the Medical Council looking at their current rule set. They will no longer be able to say, should the UK crash out, they will no longer be able to say they have an EU recognised qualification in the UK. Instead, what they'll have to say is they have a GMC, General Medical Council, UK recognised qualification. We understand what that means, and by virtue of that, once we can be satisfied that somebody has that, we will put them through an administrative procedure which is similar to the recognition for EU, but will have to be somewhat different because it's not automatic. They'll have two channels. So somebody who's got a French qualification will automatically be recognised. Somebody who has a UK qualification won't have to do the depth of analysis that somebody from a third country where we have no relationship would, but will have a fast-track approach, but will have to go through a different approach to the EU one. And our regulators will be putting back-to-back arrangements in place with their equivalents in the UK to allow that to function. In terms of the Brexit operation team, so the importance, I suppose, of that team was that, and colleagues I hope will get a chance to give you detail on this, the HBRA, the HSE and the Food Safety of Ireland have been working on this for 2 years now, and there's a tremendous amount of work that has happened. As we get to this phase, so after Christmas, what we decided was the cycle of work and the cycle of response is going to speed up very considerably to the end of March and beyond. And rather than us having meetings every 3 or 4 weeks, that what we need is a team, cross-functional from across the agencies and the department, that has a leadership and meets every week, and in between those weekly meetings is constantly engaging bilaterally. So if the HBRA needs to work with the HSE on a medicine supply issue, they can do that between meetings and report back on the Monday when the operations team convenes again. And the department is given the leadership to that to make sure that all of that happens in real time. So we've really there's been a really good collaboration over 2 years, but we've speeded up the intensity of that and made it much more integrated. So it's focusing on the full range of Brexit tasks that we're going to have to undertake under many of the differing headings. It's providing a central point for the agencies to feed into the department on. It's also allowing the department then to feed into central government. So when we go and talk in Department of Taoiseach or Department of Foreign Affairs, we're doing so having freshly just left a conversation with the HBRA, the HSE and the Food Safety Authority. So we have the most up-to-date information that it's possible to have. And then the other piece is it allows a very joined up stakeholder engagement and stakeholder communications. So on Wednesday last, Fergal led a meeting with the medicine stakeholders, so the full range of industry, regulators, the professionals that work in this area, and he did so with the HBRA and the HSE fully in the room. Everybody heard the same thing at the same time, and I suppose that is the importance in rapidly responding to an evolving situation, that people are all moving at the same speed. That's the purpose of the Brexit operations.
Thank you.
Thank you, Mr. Breslin. Could I ask Lorraine Nolan, in relation to medicines then, Ms. Nolan, the HBRA recognition and approval of drugs, will that change in a Brexit situation? Presumably existing drugs will be recognised, but as new drugs come on board from the UK, will there be a different process of recognition and approval?
Okay, Chair. Just to explain, Jim in his opening statement has mentioned the various regulatory pathways through which medicines come onto the marketplace. So I guess in light of Brexit, there are changes to those regulatory pathways that have to take place, because where there are activities that are conducted in the UK, such as manufacturing or such as batch release or testing of medicines, those activities in light of Brexit have to be changed to another EU member state. So for existing licensed medicines which are dependent on the UK for those activities to be conducted there, or for example the UK agency could be the lead agency in the technical evaluation of those medicines, all of those issues have to be transferred. So that is one consequence of Brexit. The preparations for that have been underway at European level since 2016 and are advancing. The vast majority of changes have been made. But just in fairness to the committee, we would be aware of some companies within the UK that maybe supply both the UK market and the Irish market that haven't as yet made those regulatory changes. The other system is then that after the UK leaves the UK and becomes a third country, the UK 27 will continue to authorise medicines as it currently does, and Ireland will continue to be part of that system in authorising, and the UK will obviously separate out from that process as well too. So we are working on arrangements with the UK and things like joint packaging, because a lot of the medicines that are supplied in both Ireland and the UK, obviously we have a common language, have joint packaging, and we know that joint packaging with third countries will be an acceptable process. So we have worked on solutions in ensuring that we can maintain supply of medicines into the marketplace and ensure that we have sufficient contingency in place.
So for the companies that haven't made their arrangements and the drugs that those companies produce, could that be a problem in relation to accessing those drugs?
As Jim has sort of outlined in this, we've had an extensive planning process that has been in train over the last 2 years pretty much. And at this point, we are working with those companies because in many cases of those medicines, we will have sufficient alternatives that are available, so we're not necessarily reliant on that. So this is part of the criticality assessment exercise that we are working with as well too. And I guess if it comes down to having a dependency on a medicine, we are open to looking at pragmatic ways to allow us to transition across the period after Brexit and allow supply to continue into the marketplace as well too.
Okay, thank you. Deputy Durkan, then Senator Swanwick. Deputy Durkan.
Thank you, Chairman. After Brexit, the UK will effectively be a third country, and I acknowledge the preparatory work that's been done already, and I congratulate you on the options that you've covered. Dipping a little further into the food quality controls that will apply, the UK will be a third country, will be importing and exporting to and from third countries, and presumably the EU, but if there's no agreement, that's a crash out, the scenery is slightly different. Are you satisfied that the adequate controls will be in place to ensure that the quality and standards applicable throughout the EU will still prevail, given in particular that we will be within the EU and that the UK will not? And do you envisage an EU standard to be applicable? And I acknowledge the common travel area. I'm just a little bit worried about how strong that common travel area will prevail and at the same time maintain the standards that we have become accustomed to in the European Union.
So, and you're right, the common travel area doesn't relate to products, it relates to people. So it is a different conversation then for product movement between the UK and EU post-Brexit. And we have an interest obviously in food safety in that context. There's significant preparation underway. The HSE's Environmental Health Service has responsibility for food safety as it relates to foods of non-animal origin, and the Department of Agriculture, Food and the Marine has responsibility for foods of animal origin. Broadly, that's how the division of responsibilities happens. So, for example, we have approved the HSE for 61 additional environmental health officers. That will involve checks, physical checks and checks on documentation on the importation of foods. They currently have arrangements in place for third country importation, so if foods were to come in here from outside of the EU and land in a port as their first port of entry into the EU, the Environmental Health Service will be down in Dublin Port going through products today to make sure that they're okay to come onto the Irish market. They do that on a risk basis. They don't have to go through every product. They would look at the nature of the product and decide which ones to inspect. In the event of a crash out, the products that are coming from the UK would have to have the same regime applied to them. So a risk-based approach where we would look at the nature of those products, and the Environmental Health Service would make a decision as to, based on documentation, which ones were worthy of physical inspection. That will involve a logistical operation, particularly in Dublin Port, where the Environmental Health Service from the HSE, the officers from the Department of Agriculture and Food, and customs officials from the Revenue Commissioners will have a logistical operation, a beefed up operation. They currently have one, but a very much beefed up operation that will say, here is a ship that's arriving from the UK, here are the details of the cargo on the ship, here are the lorries, here are the importers. We have gone through in advance, and we would have advance notice of all of that. We've gone through in advance what those products are, and the Environmental Health Service is interested in inspecting 2 lorries off that ship. The Revenue Commissioners, who will act as the coordination mechanism, would issue a message to that haulier that they have to present their lorry for inspection. So they wouldn't get to exit the port without an inspection. They would present the lorry and the cargo for inspection, and Environmental Health would then do an inspection and on your way at that stage. The Department of Agriculture could do the same for meat, or the Revenue could do the same because of a customs issue. That will be a logistical operation in the port, which has been very carefully planned to ensure that on a risk basis that we have controls in place, but that equally the free flow of traffic continues. So for the import, for the truck driver who doesn't have any issues, that they can get off the ship and out of Dublin Port without being experiencing traffic jams. Obviously, the person who is subject to inspection will have some delay as they have their product inspected, and that is one of the consequences of moving out of the EU, that people who are importing from the UK into Ireland will have to, in some cases, be subject to documentation or physical inspection based on risk in a way that they don't currently have.
There, Mr. Chairman, during the foot and mouth epidemic in the UK, there were very satisfactory arrangements put in place to, as it were, ensure that there was no contamination came from the UK or vice versa, and there didn't seem to be any great backlogs at ports or airports. So it was done quite efficiently and effectively, and I presume that cognizance have been taken of that in order to put in place something comparable in this case. Could I move on, Mr. Chairman, very quickly to the supply of drugs? Listening to some of our colleagues in the UK predicting a doomsday situation after they leave for this country, to what extent have you considered their views? And are there any particular drugs or not necessarily specific drugs, but a range of drugs that might be controlled to an extraordinary extent by third countries, which the UK will become? And what has been our experience in dealing directly with third countries heretofore, and in regard to compliance and in regard to availability? How do the question of generics, how is that likely to be affected? And obviously you will examine that. In relation to access for children in the run-up to the provision of our own children's hospital here, New Children's Hospital, at this moment, where do you have arrangements to refer children in respect of, obviously, the UK, to third countries, and the degree to which remuneration is readily available? And obviously, we can still do that after Brexit, but just to maybe give us some indication as to the countries with which we have an arrangement. And could I also mention my understanding, from what I know, is that any bilateral arrangements have to be in accord with EU approval, because we remain part of the EU, and will do so. And I just like a little bit of clarification on that, just in case that we find ourselves in some kind of a cul-de-sac at a later stage.
Durkan.
So on the drugs supply, and I might ask both the HPRA and the HSE to come in on this. So the starting point is a significant routing of medicines, either originating in the UK and landing in Ireland, or being sourced from the UK. Up to 70% of medicines on the Irish market either are manufactured in the UK or transit through the UK. So when we talk about the supply chain and the modification of the supply chain, individual manufacturers have looked at that. Some have made arrangements, for example, where the drug is manufactured on the continent and moves through the UK land bridge. Some have made arrangements to come direct to Ireland. Others have decided that whereas the product previously was contained within a drop for the UK and for Ireland, that they will separate out those two loads and they will send them separately via the land bridge. But there's significant supply chain modification that is underway, and a lot of it depends on the characteristics of the medicine. So if it's a particular medicine where there's long shelf life and very little potential for disruption due to a delay at a port, then there's more flexibility on the part of the manufacturer and the distribution chain. The areas that have been looked at in particular, and John has referenced it, are areas such as short shelf life medicines where a delay could lead to a product expiring, and so particular outreach has happened between the HSE and the HPRA with those suppliers to try and be reassured and verified that the arrangements in place there won't be disrupted. So in general, the arrangements in place in Ireland for the supply of medicines are quite distinct to those in the UK. Because we're an island, we have had a wholesale distribution system which is quite different to the UK one, and we have significant stocks held domestically within our supply chain. And so that is the first port of call if any immediate issues were to arise. And we are working with a range of stakeholders in the medicines industry just to ensure that they have the proper capability to respond to any disruption that might arise. Obviously, given the scale of thousands of medicines that are involved, that requires individual level preparation and planning. And in respect to critical medicines, we have an exercise underway to look at those critical medicines, to look at alternatives, to look at supply chains, and just to verify what's underway. As of today, we have no issue where we are declaring this is a problem, this is going to be disrupted. We are going to continue to engage right up to the point and beyond of Brexit to make sure that that stays the case. A background issue to this is that because the Irish market has been so intermingled with the UK market, it does mean that potentially, and I'm not talking in the next weeks, but over the medium term, manufacturers or suppliers may look at the Irish market as a smaller market post-Brexit. So whereas we were part of this huge UK-Ireland market, for some people, we will now be the Irish market with 4.5 million people, hasn't got a great supply requirement, and we may experience a situation as other countries do of our size, where some suppliers decide it's not worth supplying into that market, or they may want to supply on different terms. That's a medium-term thing that we will have to watch post-Brexit, not an immediate thing. In respect of the generic medicines, that potentially is an issue where somebody may say down the road, actually there's a lot of extra bit to do to get into that market, there's a bit extra documentation, I don't sell a lot in there, sure maybe I won't continue with that. We have to look at all of those situations. In many cases, because it's a generic, the active ingredients are being manufactured by others. So one supplier making that decision in and of itself mightn't be a crucial point. if there are other generic suppliers supplying the same active ingredient, or indeed the originator is still on the market. So I might ask the HPRA just to expand on that. I'm going to ask John to talk to the children's services and the particular linkages that are there. And in respect of our ability to conduct bilateral agreements, the EU-UK withdrawal agreement and the negotiations in Brussels specifically recognise the common travel area for Ireland as being a distinct feature of the Irish-UK relationship, and has given a licence for us to give that expression post-Brexit.
Thank you, Mr. President. Ms. Nolan.
Thank you, Chair. I won't repeat what Jim has said, so I'll just add some more information to it. Deputy Durkan, just in relation to the point on the doomsday scenario predictions in the UK relating to medicine supply, Jim has outlined very well, I think, the preparations the industry is making from a logistics viewpoint. You have to remember that in most cases that industry is preparing for almost 3 years now, and it has huge expertise in logistics, and it knows exactly how to split off supply from Ireland and look at different routing for medicines to come in. In addition to that, I think the wholesale distribution model that we have in Ireland is quite different than that in the UK, and we hold much larger buffer stocks at the wholesale level in Ireland than they do in the UK. We in general hold 6 to 8 week stocks, so you can see we have we have a mechanism within that system that we have capacity to maintain supply, even if there are delays in getting medicines transported to and from the UK. So our system is more flexible and more adaptable for that reasons. And that is just different mechanisms in which the supply chain has evolved in the UK relative to the Irish situation. You have spoken about generic medicines. I suppose the generic industry, it works on a smaller margin in terms of supply of medicines to the marketplace. Brexit, as we have said, does mean change, so I think the cost of supply to the market may go up. We don't anticipate that there will be a major impact in the aftermath of March or the end of March, that what we may see over time is a rationalisation by the industry of portfolios of medicines that are supplied onto the Irish market. We do have systems for dealing with that. Jim has mentioned in his opening statement that the HPRA has a coordinating role in relation to medicine shortages in Ireland, and we have a framework that has been put in place within the last 6 months, which is operating very well, and we do have very good capability for managing shortages. The main thing in terms of all of our Brexit contingency planning, and this has been ongoing over quite a period of time now, is we have very close engagement with the industry, and we are receiving real-time updates from them, and the operational meeting that Jim has spoken about, that gives us a mechanism for us to be able to react to an evolving situation very carefully. So I think with very careful monitoring and with kind of issues occurring over time, the situation has the capability to be very well managed if there is rationalisation in relation to generics. We also have quite an extensive supply of generic medicines in the Irish market. You may be familiar with the interchangeable lists of medicines which are published by the HPRA. So these are the list of generic medicines that are available on the Irish marketplace. So it is an aid which is used at pharmacy level for changing patients.
And manufactured here?
No, not necessarily manufactured here, but these are medicines that are brought into the country. So I suppose what I'm saying is we do have adequate supplies and there isn't any immediate concern. You raised a point in relation to third country and bringing medicines in from third countries and how the system can adapt to that. I will say the European system, which we are part of in Ireland, is very well used to dealing with third countries. It's actually set up to allow for importation of medicines for third countries. There are additional regulatory requirements that have to be put in place if we're bringing medicines in, and that would be where the product has to go through a process called batch release and testing. The developments in Europe over the last 2 years in preparation for the UK withdrawal have put in place that the transfer of those activities into other European countries. A lot of that activity for certain medicines is actually transferred to Ireland, so we have good capability to address that situation as well.
Thank you very much, Ms. Nolan. Dr. Hennessy, or Mr. Hennessy.
John, just to add a quick point to that, the high volume, low price medicines are a very specific part of the contingency planning. And just to echo Lorraine's point, we don't have huge concerns in the short term, but in the medium to longer term, there may be issues there around continuity of supply and price implications, perhaps. seeing as Ireland is such a small component of the market for those products. My colleague John Swords has been working on a number of these areas, including medical surgical supplies as well, in order to ensure continuity and availability, but no major concerns emerging in the short term. In the medium to longer term, we'll need to monitor carefully. But as Lorraine mentioned, of their nature, there is interchangeability, and alternatives may have to be sourced. But we are particularly conscious that there are high numbers of patients on these medicines, and would have become reliant or used to the same product for perhaps a considerable amount of time, particularly those with chronic illnesses. So we're not underestimating it for a moment, but it represents more of a longer-term concern rather than a short-term in the context of Brexit. And just on the children, Deputy Durkan mentioned, the treatment abroad scheme covers this pretty extensively for both adults and children, but the children represent a particular niche in terms of transplant services in particular, and we have a very close relationship with a small number of UK tertiary sites that provide those specialist services. The numbers wouldn't be sufficient to provide that level of service within the island of Ireland, and our planning focus has been on, and there has been very extensive planning on this, but the focus is on ensuring that access route remains open and remains available, and the agreements with the individual sites in the UK are developed in order to ensure that post-Brexit. But as I say, the particular concern, and where there wouldn't necessarily be readily available alternatives to UK sites, would be in the area of transplants for children. John, I don't know if you wish to add anything.
Many of that with the view to an alternative in the event of there being a difficulty gaining access to the UK site, either for children or for adults.
Yeah, we have done some work on that, and the concern would be I think the Secretary-General mentioned earlier, very close relationships have developed over the years between Ireland and the UK that have grown up on the basis of consultant-to-consultant referral, and there's a high degree of comfort, if you like, among Irish clinicians in relation to these sites in terms of the service they provide. To be frank and truthful about it, it would be difficult in the short term to develop alternatives across mainland Europe for many of those services, and therefore our efforts are on ensuring that continuity remains post-Brexit, in the short term at least, with the UK sites. Over time, I think we will be looking to develop relationships with alternative providers. And again, to be fair, there is treatment abroad activity in other continental countries from Ireland that we want to develop. But I don't think any of us would like to be reliant on that in the short term, and therefore we need to maintain our connections with the English sites, with the UK sites.
Thank you very much, Mr. Hennessy. Are there any particular concerns in relation to vaccines as opposed to medication?
John, may I comment again on that?
I think I might make a couple of points about supply chain. First of all, I think it's important. You mentioned, is there any learning from what's happened in the UK and so on? Over a year ago, the UK government issued an intention, a directive, to say that they wanted to stockpile certain items, and they wanted to go as far as 6 months for all the companies. And we had at that time been in discussions with our supply chain people in the drugs and in the medical and surgical area, in the food areas in particular. They're the three key areas that we've concentrated on for Brexit. But nonetheless, the key to any supply chain is an even flow of product rather than stockpiling, because stockpiling actually creates difficulties, and that's evident now in that some of the hospitals are finding it difficult in the UK to get product. Even though there's enough product in the country, there's an abundance of product in some areas, but they haven't got it when they need it, which means there's a redistribution and a cost associated with that. Our strategy has been to keep an even flow of product, and as Lorraine mentioned, as Jim and John have also said, that we have enough stock in the country at any given time to allow us to plan forward. To give you a bit of an idea around that, we have a national logistics plan in the HSE. We have a national distribution centre with 9 hubs around the country which we supply out into community and hospitals from there. We have 6 weeks stock at any given time across 6,000 stock keeping units which supply on a regular basis to the items that are required and used in the hospital. So that's one area of security, and we'll monitor that as we go forward. In relation to drugs, we've met with all the umbrella companies, and we're meeting with the companies, the main distribution companies, seeking to see what they have in place and also to reassure ourselves that the actual stock is there. And we've been very encouraged by what we found, because as Lorraine said there, the 6 to 8 week stock in the wholesale, there's a further number of weeks in the manufacturing process at any given time. And there lies the secret to our success in maintaining that supply in an even way and not knee-jerking across the system and causing peaks and valleys which could actually in actual fact have an effect on employment. And we have manufacturing in Ireland, so we don't want to disrupt any element of the supply chain, but it is a very, very refined and mature supply chain, and everybody is encouraging us not to overreact. Now, if we stay sensible on this and we stay in communication, which the way we are currently, we'll be able to see if on the 29th of March, if there is a break, it's later in the year that we'll see any real impact, because we'll start seeing the ports filling up or whatever that may be. But even allowing for that and looking for securities of supply, particularly in the short life areas, we've met with the suppliers of products, and they have brought in enough manufacturing raw materials for 3 months in some cases, and they're upping in some cases to 8 weeks on the overall supply. But we're learning all the time about our supply chains, and we're probably getting more information than we ever had, and we're getting more educated in how we will deal with any shortages. The shortages framework has worked very, very well to move more from the drugs area but into the food area. There are shortages on an ongoing basis with food supply. One of our main suppliers of ambient food which source foods all over the world, they bring shortages into us from time to time, and we discuss any shortages that they have with our catering officers which are on the ground providing the services within health, and we agree any changes that have to take place to ensure that spurious product doesn't get into the supply chain. But that's very, very closely monitored by our catering officers. But nonetheless, it's a good example of day-to-day shortages happen within any supply chain. And what we have to do is just maintain that and keep an even flow of product and encourage everybody to be sensible about it. In relation to community pharmacists, just by way of information, there's 1,800 pharmacies that are delivered to, on average 11 times per week through the distribution service, and there's numerous pharmacies within different communities, so they rely on each other, and it's very, very mature and well stocked. There's up to 4 weeks in the pharmacies themselves, and there's 6 to 8 weeks in that supply chain. So we don't see shortages right now, and we don't see difficulty with that. We see that it's been well managed, and I think probably the encouraging thing is that there's a huge amount of communication going on at the moment. We've written to over 300 of our main suppliers. We've had 70% success of return back, and a lot of that information is coming back to saying that they have examined their supply chain. They're looking at 6 to 8 weeks, in some cases 3 to 6 months. The generics that you mentioned there, some companies, smaller companies, are actually stocking up to 6 to 12 months. So they're making sure that we don't have an interruption in supply. And another point to note is that we deal a lot with distributors. And because of that, we have options within our supply chain. As we rationalise our logistics operation within health, and we've been doing so for the last number of years, we're extending that into the Dublin region now, but we are bringing efficiencies into that. We're actually reducing our inventory in a lot of areas. On average, we keep 2 to 3 weeks of stock in hospitals across all our areas, but we can rely on each other in the event of any shortage within any given area. But the main point is that we are in control of our information, and we're getting better and better at that. And as a result of that, Brexit, while it poses different problems for us and questions for us, we're in a situation where we can answer those questions. Our one risk, if you want to call it a risk, is that there may be a delay of product, but there's enough in the system, and reassurance that I could give you, that there's enough in the system to sustain a shock, and we look at that. In relation to drugs that might be required on a very quick short-term basis on a turnaround time. Customs have indicated to us that in the event of paperwork being in place, they will give it a blue light service. Now, that's as good as it gets, because we've also spoken to suppliers about, instead of just using road and rail and ship, that we'd use air freight. And those arrangements are in place with some of the companies at this point in time. So we're examining, and we're also going out to meet our main suppliers to ensure that they understand where we're coming from and that we work together on this issue.
And in relation to vaccines?
Vaccines, Chair, fine. The population health colleagues have tested the supply chains for all the immunisation programmes. Most, by the way, come directly to us from Europe and don't come through or touch the UK at all. So all have come up fine, and we have solid assurances around those.
Thank you very much. Now, Senator Swanwick. Thank you.
Thank you, Chair, and thank you all. Many of my points have been touched upon, but I welcome what Mr. Hennis has said earlier on with regards to the organ transplant programme in Great Ormond Street, and also the collaboration between the ambulance services in case of major emergencies and major incidences and emergencies. I suppose the other thing that my colleague Senator Burke mentioned with regards to young health professionals going to the UK to gain experience, I think that's invaluable, and I spent some time in South Wales myself and completed my GP scheme there. And I think young health professionals gain invaluable experience in that regard, and I would hope, working in a different jurisdiction, and I would hope that the postgraduate qualifications, and I know it's probably an issue for the postgraduate organisations, but like, for example, if a young doctor completed their GP scheme over in the UK and gained qualification, maybe became a member of the Royal College of GPs, that would be reciprocated with a membership of the Irish College of GPs on returning to Ireland. Hopefully that they would return to Ireland to address some of the shortages that we have here. But I know we've had a long discussion with regards to drugs and the supply chain, and I recognise the collaboration between the department, the HPRA and the HSE. And I also acknowledge that obviously the challenges with regards to refrigerated products and products with short shelf lives. You mentioned about the vaccines briefly and the 2-month supply. We're quite happy that that is enough supply to have. And I presume you meant childhood vaccinations. What about travel vaccinations as well? Would that come under that sort of grouping? And also with regards to cancer drugs and immunotherapy and biological agents, because Mr. Breslin said with regards to critical medicines, would biological agents come under that critical medicines banner? Because often now you see with conditions, rheumatological diseases, for example, rheumatoid arthritis, or something like inflammatory bowel disease, consultants are going straight in with a biological agent straight off to get the patient's symptoms under control quickly. Whereas previously, they might have used a disease-modifying agent or something and built up to a biological agent. Nowadays, often it's a first-line treatment. So the demand for that product is obviously a lot more. So are you happy that, because they're used in such a wide variety now of cases, be it GI cases or joint cases or whatever else, are you quite happy that we have enough of those types of drugs available? And I recognise what you said with regards that we have good links with multinationals, and there are excellent wholesalers in the country. And as you said, and correctly said, medicines shortages is an ongoing issue with or without Brexit. And for me as a GP on the ground, I'm beginning to see patients requesting extra drugs. And that is because people are seeing the charade and the disorganisation in the British Parliament, and combine that with the deadline of the 29th of March looming. So once again, I suppose GPs are acting as gatekeepers in a role that they didn't think they were going to be acting. I'm trying to reassure people. And I know there are public campaigns, awareness campaigns, but would you consider maybe redoubling the efforts in getting that message out to the public on the ground, in the form of a media awareness campaign, radio and TV campaign, not the panic campaign, because people are asking for more inhalers, more blood pressure drugs, and people who are on these biological agents are concerned that the consultants will not be sending the high-tech scripts down to their local pharmacy in order for the local pharmacy to dispense them. I think that's a real concern, and I think really, whilst as professionals we're okay and we can be reassured by your comments. I think on the ground there's a bit of a disconnect, obviously, where people are worried about their conditions, that I think that a public awareness campaign would really help to benefit those cohort of patients. Thank you.
Thank you, Senator Sonic.
Coincidentally, because I signed it off last night, we have mentioned it earlier, communication to go on medicines to a range of stakeholders. Included in that is the ICGP, and importantly to give their network of GPs the knowledge so that when the patient does come, they're able to say, well, actually, here are some key things that I'm able to tell you in relation to that. We will look at this. As I mentioned, we have a communications team in place. We will look at this. At the moment, we're getting great free messaging out because people are asking, just as you are today, are asking questions and the newspapers are writing it. As we come closer to the time, we will look at potentially having to put our own public messaging out. We have to think about that because this is a situation where you don't want people to do things, so if you say to them what you don't want them to do, they hear what you're saying and they perhaps think that's what you want them to do. So this is why working through professionals is really important. So the IPU, the ICGP, so the local community pharmacist is able to say, well, hold on a second, actually, you know, this is the real situation. I know you saw something across the water, but actually it's not the same here. So we will be doing more and more of that and continuing with that. In relation, the other point I think you make about medicine shortages already being a feature and have been a feature is absolutely correct. With 45 medicines on a current list at the moment, but with the HPRA and the stakeholders with a medicine shortage framework in place to address those, the last thing we want, and I know it's going to happen, something is going to run short in the period ahead and somebody's going to say that's because of Brexit. There's every chance it'll be because of a manufacturing issue or an issue that has arisen for a completely different reason. So we just have to keep clear as we go through those issues what the source of that is and work with stakeholders to explain that and not have erroneous information make its way into our system. In relation to the biological agents, I can ask John, our HPRA, to talk about the critical medicines assessment process, but essentially that is what we're interested in, building upon the overall message that we've got from manufacturers and wholesalers that they have this plan for and they have sufficiency, is to say, in the case of medicines where because of their characteristics there could be a critical issue if they weren't available, we want an extra layer of verification. We're doing that by category, so actually that's important because what's important is that you have a medicine within the category that you will be able to prescribe in that situation. So there would be some interchangeability, and the professionals are doing this. The doctors through clinical programs and the pharmacists are sitting down and saying, there's 4 and we definitely need supply of those. If we had a problem on 1, we would still be okay. But that involves more detailed conversations with people where you're saying, in the case of these, give us an extra level of reassurance and an extra level of verification that should be okay with regard to those. We are going through that process. We are not complete and we won't complete. We'll keep doing it and refreshing it as we go along. The important thing is just because a medicine is critical doesn't mean that it's one that we're concerned about, because it could be critical in coming directly to Ireland from the continent and there could be no disruption. It could have features to it which mean that even a short delay of a week or 2 is not going to impact our supply. So we have to not just examine ones that are critical, but also then examine what's the current supply chain, and that's the level of analysis that we're bringing to bear on it. I could be corrected, but I'm not certain that the travel vaccination is in that process. I think it's probably the more general process of checking levels and working with manufacturers. Importantly, the regard that's been had to medicines by the HSE is not simply about medicines that end up in hospitals. It's about medicines that the Irish public will need, and that includes true retail pharmacy prescribed by GPs. So we have to take a public health view of this and not just which are the ones that we order. We have to understand some medicines will be critical but will be dispensed in the community, and they're just as important as medicine that's dispensed in hospital.
Thank you, Senator. Now, Deputy Louise O'Reilly.
Thanks very much, Chair, and good morning to you all. I won't say good morning by name. There's more use than there is of us, so we'll be here all morning. Just to, and look, it won't be lost on any of you, but the reason I was late is because I was down on the picket line with the nurses this morning just to show solidarity in the same way as I would with any public sector worker or civil servant fighting for their rights and entitlements. I'm just wondering, and I've read through the submissions and I apologise for being late, in terms of the implications for the workforce, because certainly the evidence suggests there's a struggle to recruit nurses, and without getting into the dispute, there's a struggle to recruit other healthcare professionals as well. And is there any sense within the groups that are working on this that Brexit is going to have an impact, negative or positive, on workforce? And is there part of the, because I can see that a lot of work is being done, which is very welcome, because we did have an engagement previously where maybe the same level of work or engagement wasn't obvious, but there is a level of work being done now. Is there someone looking at the implications, the potential implications for workforce planning? So obviously you've got the mutual recognition of qualification stuff, and that's been discussed previously. But in terms of, my sense of it is that the British Health Service have gone out in a very aggressive way to target staff because they have a fear over the implications that Brexit will have for their staff. And I'm wondering if we are countering that, or if we're seeing anything from that. If you don't mind, I'll ask all the questions together and then we can, if that's okay. You mentioned the need to raise awareness, and it's in the submission there that the HSE is continuing to work on awareness of Brexit among the HSE, the health service staff, key suppliers, with patients and with the public. And I know that there was some discussion on this, but I'm wondering, and I appreciate the dilemma because you don't want to panic people, but by the same token, people are starting to think, because for ourselves maybe we've been focused on Brexit for a long time, but now I see that a lot more people are starting to sort of focus their attention on it, and they're worried. I have spoken to people who were nervous and asking, should I get 6 months of my next prescription? Is there going to be an issue? And the fact is there will only be an issue if everybody goes in and starts to stockpile. If people start stockpiling it, then there will be an issue. I'm wondering if any consideration has been given, and I respect the fact that this is tricky, I do know it is, but if consideration is being given to maybe a media campaign, more than just talking to the professionals, but something along the lines of television or radio or newspaper advertisements, that might, if that is being considered. Page 2 of the department submission says, it would be impossible in a no-deal scenario to maintain the current seamless arrangements between the EU and the UK across a full range of sectors which are currently facilitated by our common EU membership. So we know that it's not going to be, there's no such thing as a good Brexit, and we've said this repeatedly. We didn't vote for it, clearly. Actually, nobody on the island by a majority voted for it, but we are where we are. So I'm just wondering, what are the areas where you see, in the event of a no-deal scenario, and we wake up the day after, where are the first implications going to hit? And will there be a requirement at that stage for legislative change, or will the legislative change have to come in advance of that? Because I know there's reference made to that. And my final point is one that relates to the provision of cross-border services. And this is something I was at the weekend at a conference in Belfast, and I was also at a protest on the Border Communities Against Brexit protest, and I suppose possibly because I'm the health spokesperson, but it is something that was raised with me, just in a very casual, and this is anecdotal, but people were asking questions like, for example, the GP out-of-hours service that operates between Cady and Castleblaney. There's the same one operating between Altnagelvin and Inishowen, and it works well because they're geographically close. Can they be fully sure, in the event of a no-deal Brexit, that service will continue, or is it anticipated that there will be a break in some services while arrangements are made? And I say this not to be critical, but I say it in full recognition of the fact that it is not the fault of any person in this room that we found ourselves where we are. But I'm just wondering, is it anticipated that there will be a break and then it will be necessary to do work to restore those services, or is it anticipated that services like that will continue seamlessly? We had an engagement previously at this committee, and I asked questions about whether or not service level agreements and stuff had been Brexit proofed. And the answer that was given, to be fair, was probably the only answer that could be given, which is that there was an element of we didn't know. So it was almost a year ago. I think it was the beginning of March. There was an element of we don't know, but at that stage you couldn't have predicted that that maybe things would go in quite the way that they are. And the level of unpreparedness in Britain is something that concerns me, at the impact that may potentially have on us. And it's clear that while we could do all of the work to prepare ourselves, we have we are geographically close to the people who may potentially undo any work, any good work that might be done. So I'm just, in the case of those specific services and where there are cross-border services, is it anticipated that there will be a break, or is it anticipated that they will run seamlessly, and what are the potential legislative implications? Thank you, Chair.
Thank you, Deputy O'Reilly. Mr.
Okay, I might work backwards, and I'll ask other people to come in on them too. In relation to the last one then, it's not anticipated that there'll be any break. We have a confidence around that. John has talked about the service level agreements and the Brexit proofing of those, which has been completed. I'll also ask him to talk about COT, because some of those arrangements are under a cooperation mechanism that we have, but we're not anticipating anything. And actually, if I link back then when you say what are the impacts across sectors, I noted at the early in the meeting, the Times of London has ascribed they jumped from that statement, which was a general statement about Brexit writ large, into Secretary-General says medicines will be okay, but cross-border services are going to be impacted. I haven't said that. In relation to cross-border services.
Clarification is welcome, but I think it does underline the need maybe for a media awareness campaign. But that's because I read that as well, and it clearly wasn't.
Yeah, when I talked about the impact across sectors, and some of the discussion has maybe highlighted some of the areas, there are things that are currently automatic that won't be automatic when the UK becomes a third country, and we've had two examples so far. One is in the area of food safety. When product is moving east-west, at the moment it's moving within the EU. If the UK crashes out when product moves east-west, it will be a third country that the product will be coming from, and there will have to be a risk-based decision as to whether the documentation is pulled and there's a physical inspection of that. And we are putting 61 staff into the HSE to do that. So we're spending $6 million on staff. If we could have that $6 million to spend it on patient care, I would much prefer it. But because Brexit is happening, that's what we're doing. Yeah. So going from a situation that was seamless into one that we have administration overhead is an example of the impact that Brexit has on this country and on the UK. The other one is, as you've identified, professional qualifications that are currently automatic. We will have a procedure which makes it smooth and seamless, but it will require an extra procedure. It won't delay things, but it will require us to have it's an EU qualification, therefore it's automatic. We will have to say it's a UK qualification, but we understand what that standard is. We're applying our system to recognise that and check you can be recognised here. So it's just an extra layer that will have to be built into it. On the question of awareness, so we're actively considering our communication strategy. We're working through intermediaries. I think particularly health professionals, GPs, pharmacists, also patient groups, and John can talk to that. I think there's particular patient groups that would have particular anxiety. If we can give them information, then they can talk to their membership as well. There may be a point, and you've posed the question, what would the content be and what would the timing be? We're actively considering that, where we would more publicly push messaging out in a more visible way.
Yeah, no, and I do appreciate that has to be balanced, but it's something that I think at this stage you nearly couldn't rule out on the basis that, just anecdotally and no more scientific than that, but I have spoken to people who are saying, what do you think? I'm going to get a few extra just in case, and it's to be able to put people's minds at rest and say, look, there's no need to do that, and if you do that, actually what you'll do is just contribute to the problem rather than any solution.
Just further reminds me on the question of legislation. So the heads of bill that were published are to be introduced before we hope this won't happen, before a no deal crash out, and that's subject to the drafting and bringing it through the Oireachtas. But the intention, the proposal set out in the legislation, which would sit above what we've talked about and would allow, for example, the HSE to reimburse services in the UK that are treating Irish patients. That legislation is intended to go through before the 29th of March. And then the last one, before I ask John to come in, on workforce. So there is a degree of speculation about this, and certainly we're not in the realms of this is going to impact us in April, but it will change potentially the kind of global supply and attractiveness of the UK. So one of the things that may happen is professionals that are trained elsewhere in the EU may no longer find going to the UK attractive, and I think the UK is seized of that, and so then they will look at a situation where they may be running into shortages. And actually, when you talk to them, they're just as worried about I don't want to say non-professional healthcare staff, because all healthcare staff are professional, but non-professionally qualified. So cleaners, porters and other staff, where actually there may well be shortages, because a lot of those traditionally have been filled by foreign nationals in the UK. Their response to that may see them say, well, English-speaking health professionals, where else could we get them? And they could target themselves at us. Equally, we would be more attractive in that situation, because EU-qualified professionals that wanted to come to an English-speaking country will no longer have the UK to go to and may be interested in Ireland. So it's push and pull, and it is hard to speculate on it. What we are working on is getting the professional recognitions in place that would allow us to be able to move in the event of any patterns that do develop. So I'll ask John to come in on the...
Just a couple of points to add to those and Deputy O'Reilly's concerns. I'd ask Paula Keown here to talk to the North-South dimension, because she's been very close to Brexit proofing the agreements, if you like, that between the various providers. And we mentioned some of them, but you're right, the GP out of our service is an important part of that programme as well. In relation to the information, we have been extremely conscious of the need for clear, reliable information for the public and for patients. And I think you're going to see evidence of a lot more proactive communication from this end over the next 4 to 6 weeks. It's already kicked off with some stakeholders in relation to suppliers. We're meeting the National Patients Forum, which would have representation from most of the advocacy groups, the patient advocacy groups, and in particular those with chronic conditions. We're meeting them next week to provide information assurance where necessary on particular issues like medicines and supplies, and I think we understand fully how people would be concerned about those things. And with the benefit of good, reliable information, we may be able to prevent the kind of stockpiling tendencies that you referred to there. We're watching closely at the supplier end, by the way, on that as well, to see if there are any unusual patterns of ordering from particular sources. By the way, included in that, and Senator Swanwick mentioned it, included in that programme of communication would be GPs and pharmacists and prescribers generally, to help assure people about supply chains and to try and manage that. The workforce issues, I think the Secretary-General has covered most of those. The HSE HR department has analysed in great detail the Brexit implications throughout or across the spectrum of qualifications, training, education, recruitment as well. And we have a good handle on the implications there. I might ask Paula to touch on the north-south dimension.
Yes, Deputy O'Reilly, you're correct about the GP out of hours is a very important part, and I'll get to that in a minute. In fact, there's 30 years of intensive work, cross-border, north-south, built up over the years. And for those of us who live on the border, it's very much the norm that you may get a service in the other jurisdiction. In fact, it is since 1992 there was a formal arrangement, the Ballyconn Agreement, where the services north and south set up the cross-border CAUT organisation, which is cooperation and working together, largely using Interreg funding, European funding, to seed projects north and south where we can use economies of scale, where we can find solutions that we couldn't find because of our geography distance from the urban centres. In order to Brexit-proof our current range of work, which is an Interreg 5A 30 million project, to Brexit-proof it, we have it underpinned by Her Majesty's Treasury with the Department of Health. We went to the UK in order to seek assurance that the current round of funding will be secured until the end of the programme of funding in 2020. Now, the future of European funding is obviously uncertain and probably part of the future arrangements. So we have to see what happens there, but the current round of funding that seeds these projects is underpinned. Then outside of the Interreg funding, they were touched on earlier, there are lots of north-south work going on. At the Radiotherapy Centre, very innovative, single capital build, only capital build in health on the island of Ireland, 2/3, 1/3 built, 2/3, 1/3 patients. A second one is the primary PCI, which is clinically absolutely the solution for the patients of Donegal. They only have a 90-minute window for their stents. It's absolutely the solution for our patients. We did a mapping exercise which would look at all of these service level agreements, memorandums of understanding, including the ambulance service, including the GP out of hours service, which again was the solution for 243 patients, as you mentioned earlier, in 2018. And we have all of those mapped, and they are underpinned by the common travel area. So, as Jim Breslin said, it's not anticipated that day one there will be any break of service.
No, and just on that, you mentioned the Interreg funding
Yes.
for the CAUT, and I'm very familiar with that organisation and the work that they do. How long is that Interreg funding, the current round of funding, how long is that for?
Up to 2021.
2021, okay, thank you.
Just to say, Deputy, I know from the publications that the Commission has made in December of 2018 that there is a recognition in Brussels on the importance of those funds, and as has just been said, a commitment to continue with the current programme, but also looking at the importance of building upon that. So I don't think, even in the context of a no deal, that Brussels would simply say, well, that's that over with. And certainly the UK authorities and ourselves are committed to trying to continue cooperation.
Excellent. Thank you.
Thank you very much, Deputy O'Reilly. And Deputy Kate O'Connell.
Thank you, Chair. Thank you all. Nice to see you again, Mr. Breslin. Just a couple of things I want to check with you on the, I suppose, the reality, and Deputy O'Reilly there mentioned about the anecdotal evidence. My understanding is on the ground that people are, older people in particular, are stockpiling, especially drugs with narrow therapeutic indexes and all of that. So, and if in the case where a GP is issued a 6-month run-off of GMS prescriptions and they're legally presented to a pharmacy and they have the stock on the shelf, you can understand the conundrum when you're faced with a real-life distressed person concerned about the future, and perhaps, you know, their news is Sky, not BBC or whatever's feeding their fears. So my understanding is on the ground people are stockpiling, and I am concerned about it. And I've heard various reports, I'm not sorry now for being late in here today, but that we have about 10 or 12 weeks headroom in the supply chain for medication. But obviously if people are getting 6 months of prescriptions, that depletes our headroom. So my question to you is, often in retail pharmacy where there is a shortage of products or there's a control aspect to products, there's a limit to the amount of packs you can get in a month per business. And I assume somebody put something into a computer, and once you get your 20 packs, you get no more. Have you considered or have you imposed anything like that, in the sense that a retail pharmacy dealing with one of the big suppliers, that you would limit perhaps their ordering this month to 1.2 or 1.1 times last month's? So that's my first question. Like that, I know there's talk there of a media campaign. I just would urge caution there, in the sense that you say to people, don't stockpile, and the first thing they do is get a truck and fill it full of their tablets. So that's just the nature of people and the survival instinct. When it comes to the actual real-life supply issues, some of the products we're getting in through the UK, so I'm specifically talking about bespoke feed bags, TPNs and specials. I've heard in here, and I've heard in my own party, conversations about you've engaged with the manufacturers. Are we sure that if there's a no deal and there's a crash out on the 29th, that my understanding is about 80% of some of the TPN comes from one place in the UK. Are we able to feed those people in April? Have we the capacity to supply ourselves, or a stopgap situation? Or have you something in place that somebody waiting in one of our acute hospitals for their nutrition won't be left hungry? Thirdly, regarding the marketing authorisations and the dual labelling arrangements we have with the UK, my understanding is, and perhaps Ms Nolan might be the expert on this, that we sort of piggybacked off the UK in terms of packaging for a long time. My understanding is, regarding marketing authorisations, that most of them are authorised through the UK, where the QP, the qualified person, is domiciled in the UK. So if there is a hard Brexit and they're not in the EU anymore, the QPs that are authorising the meds and responsible for pharmacovigilance will no longer, to my mind, be allowed sign off, because they won't be domiciled. So then we have a conundrum where we speak English and nobody else does. So are there provisions there in the case of a no deal? Have we spoken to the Dutch or other friendly countries that would maybe print the other side in English or whatever? Have we something in place to deal with the fact that we're piggybacking off the QPs in the UK, and that may no longer be possible? Regarding the professional qualifications, as a UK graduate myself, I'm interested in this, and I understand you're saying there'll be an extra layer, but that's just assuming the standards stay the same. So that's really only, Mr. President, with respect, a short term. So if you graduated, they hardly would have let the standards fall too far by this summer. But theoretically, we can only add in that extra layer if there is alignment in terms of standards. So is there any plan thereafter? I know we're talking about sort of things that could happen, X, Y or Z, that could happen based on whatever happens across the water. I think that's it for the second. If you can give me those answers.
Yeah,
and then
if I
I'll
might
come back
start
to you.
at the end then, and we touched on it earlier where I talked about the recognition of qualifications but the risk of divergence and how that presents. So I suppose we have different scenarios. We have the arrangement that will be in place in the context of a no-deal regulator to regulator, based on the fact that we currently know that the standard is equivalent. We have an ideal scenario. Well, the most ideal scenario is we have an agreement to no deal. The next would be that in the future relationship between the UK and the EU, there is something concluded about qualifications EU to the UK. That would be great. Then we would be back fairly close to where we started from. In the event then that the UK and ourselves have a bilateral arrangement, it will be necessary for the two regulators. It won't be a bilateral arrangement so much as the two regulators will understand the qualifications in both jurisdictions, and because they're equivalent, will be able to recognise them. In the event that they moved away from being equivalent, then that will be an issue, and that will be an issue for both regulators. Like that won't happen by accident. Somebody is going to have to decide that they want their professionals to be different to the EU. That'll be a big decision to be made in the UK, but our regulator would have to make that very clear what the implications of that would be and plan for that were it to happen. And that's the same for the whole EU rulebook. Like, it's not just professional qualifications. If the UK diverges from the EU across any element of standards, then it has implications for trade, it has implications for movement, it has implications for all of those things. So it's a big policy question for people who have a lot on their mind in Westminster at the moment. If they got that freedom, how would they use it? In relation to most of the other areas, I think Lorraine might be able to talk, certainly on the dual labelling and the MAHs, possibly on the TPNs. On the shortages, equally, I think it would be helpful if the HBRA just talked about the medicines shortage framework, but certainly to say we know at the moment from the contact HBRA and HSE are having with wholesalers that they are looking at ordering. They are looking at ordering to ensure that there are no artificial reasons for product being taken down, and they will continue to do that up to and beyond Brexit. Lorraine, would you?
Yeah, no problem. I'm going to start where Jim ended on ordering, just working through things in that way. Deputy O'Connell, the wholesalers already have a process for putting stock on allocation when there is a concern in relation to supply and availability. So as we kind of work through and we identify products that could be impacted, and we're not at that stage yet because we haven't identified, those processes can be activated. So that system of controlling what's supplied out to pharmacies exists and can be activated and put in place. So I'll come back to maybe, and I'll start with the TPNs and the compounded products. You're absolutely right in relation to those, and we would have identified those as a category of products that would have particular kind of risks arising from Brexit, basically because a lot of them have short shelf lives and some of them may require particular storage requirements. So if there's any delays in getting things in through the ports, that can't actually happen. So there are 3 suppliers of TPN compounders in the UK that we work off, and we have engaged with those and compounding companies that are based in Ireland as well. In all cases, they have told us that their Brexit planning is well developed. They have increased their stocks of component parts, and they're looking at their logistics in terms of getting products into Ireland. Some of it is routed through the UK, but they're looking at direct fly into the UK, and we are engaging with them almost on a weekly basis to get updates in real time. It's an evolving situation, and if we become aware of any concerns, we will take the appropriate measures to address that. At the moment, we haven't been informed of any concerns in relation to those supplies. You then mentioned the conduct of regulatory activities, which there is quite a lot, obviously, given the UK's history in terms of pharmaceutical manufacture, etc., that are conducted out of the UK. You specifically mentioned activities like QP batch release and the pharmacovigilance QP residing within the UK. Over the past 2 years, the regulatory system across the European network has been preparing widely for this, and we have also been working with the companies. It's the case that the vast majority of companies have worked to actually transfer those activities out into the other EU 27 member states. Some of that work, and specifically in the area of QC testing, for example, a lot has been transferred to Ireland, and similar kind of transfers have happened with the batch release activities and the QPV. So in relation to that, we don't have necessarily any concerns. The joint labelling, I think it has been an issue that we have been working extensively on, particularly because, as you mentioned, 60% of the medicines that are supplied in Ireland do have joint labels with the UK. So I'm going to pass to Rita to speak to you a little bit about that, and just to say in terms of arrangements with other countries, we have been exploring the possibilities of coming up with joint labelling with other EU member states. We've had quite extensive discussions with Scandinavian countries in relation to this. There are challenges associated with that because the look and the feel of products will change very much for both healthcare professionals with the patients, but it is something we are developing as a contingency. So I'll pass to Rita on the joint labelling with the UK.
Thank you, Deputy O'Connell. We recognised very early on that from commercial reasons it's really important for companies that they can treat Ireland and the UK as a common market, and joint labels underpin this for many, many years. Having looked at the situation, we have publicly stated since Article 50 was invoked that provided the labels continue to meet the requirements of the EU directive, we will continue to accept UK-Ireland joint labels. Now, that position was slightly at odds of advice that the Commission had given, and we've been lobbying very strongly on that, and I'm really pleased to say that as of Wednesday last week, the Commission has come out and accepted the Irish position. So provided those labels remain, that there's, I suppose, regulatory convergence, we will be able to accept UK labels information on Irish packs. So we'll continue to see Irish UK labels. To address that risk, will there be regulatory divergence? Well, the UK has quite strongly said in the foreseeable future they are going to continue to apply the EU regulations. And given that the UK will now become a small market in terms of the EU, so we have a 600 million population and there'll be 60 million, I think there's quite a strong incentive, certainly for all the international global products, that they will remain largely convergent. And we've also spoken with both the human and veterinary regulators in the UK, and certainly their position currently is that they will work with us to make sure that we can keep that alignment in place. I mean, realistically, will that continue 5 years down the road? We don't know, but in terms of the next number of years, we think there's a good grounding to continue having that shared labels and leaflets, which hopefully will make the Irish market remain more attractive commercially to pharmaceutical companies.
I think it's a bit like the qualifications. Once things stay the same, it's all fine. But if they change the goalposts, we have a problem. As such, perhaps in 3 years, if their standards change, we can't obviously, and they're not compliant with the directives. Well, then we need a new option. I think that's all the questions answered. Happy, honest, Lorraine. Did you want to?
I'd just come back maybe to the point on shortages. I know in some of the earlier responses, Jim has just mentioned the fact that we receive about 45 shortage notifications per month. It's very important for the committee to understand that out of those notifications, less than 50% of those actually go on to be a situation where a medicine is short. And in all of those cases, and we've had 90 of those shortages in the past 5 months, we've never had a situation where a patient has been left without a treatment for a particular condition, because there have always been alternatives. So just important maybe to get that point across as well too. And maybe if I pass to Katrina just to speak a little bit about the shortages framework and how that operates in terms of the engagement.
I could just ask you, it's about 45 minutes every month forever, isn't it? Brexit is no different, because that's something that has to be got out there. There's always a short medicine list.
That's it. Well, I wouldn't say there's always a shortage, because there's a situation that's well managed.
There's no product on the list at the moment that's affected by Brexit. That's important to say. So the 45 would be there whether anyway, Brexit was here or not.
Yeah.
Thank you.
Dr. Fisher.
Thank you. Deputy O'Connell, the framework that we have in place for managing shortages, so this was put in place with stakeholders across the range who be dealing with medicines, including those who market medicines, the wholesalers, distributors, the manufacturers, with the healthcare professionals, patient organisations, with the HSE. So all of these stakeholders came together to develop up this framework where we in the HPRA coordinate the management of shortages, but it is with all of these stakeholders. So taking actual notifications that we receive, the 45 notifications per month on average, they come mainly from those who market the products. They will notify us. Some notifications might go to the HSE and we can share information on potential shortages. We ask that the company who is marketing the product will do some impact analysis and make proposals as to how they will deal with the shortage. We then validate it. In some cases, as Lorraine said, it's actually not a shortage. It might be a shortage in one area of the country, but actually there's no shortage of the medicine in the system. So we validate it, and of those that are confirmed, potential are actual shortages. So we deal with them. If it's a potential, it's not happening at the moment, but it's possible that it will be short in the future, or an actual shortage, then we will do a risk assessment again on the impact on the patients. We do manage all of them, but the high-risk ones are about 10 to 12% of the total number that we get. So most of them are quite readily managed. We'll look at the stock in wholesalers. We will get clinical advice if we need to tell prescribers and pharmacists what to do in this situation. We'll look at alternatives. We look at the market share that other companies have. We'll see if there's other strengths, other formulations, other generic products available. And then with the company, we will manage that, communicate out to healthcare professionals if we need to. And all those that we confirm as medium or high risk are then put on our website. So there is a page on the website that then describes the shortages that are ongoing at any one time, so that anybody, pharmacists, doctors, or indeed patients themselves can see what is short and when it is likely to come back in. So all of them to date have been managed with alternative formulations or alternative sources. And as I think Lorraine has said, in no case to date has actually we've needed clinical guidance to be issued. There has been no change in the treatment options that are available to patients. And there is no backlog. We deal with them, the 45 notifications per month. We have resources that are sufficient to deal with those.
So just finally, Chair, if I might, just in terms of the MHRA in the UK, your equivalent, have they said anything about in that short-term period that they will let the EU in to inspect? Is there any preliminary arrangements there, or are they just staying quiet about it? Just in terms of the regulatory alignment.
I suppose they're in quite a different position than we are, Deputy O'Connell, in relation to this. I mean, they've been very clear about their intention to remain aligned with EU law, but they do say with the caveat insofar as possible. Mm-hmm. So I guess, you know, your point is that it is a situation that we have to keep a close eye on in relation to joint labelling. You know, what's there now, you know, as things move forward, we may not be able to pull on that. So we are looking to future-proof our system and our supply channel all the time. In terms of arrangements, in terms of inspections and that, the UK is adopting a situation where it's going to recognise all of the EU systems and all of the inspections done by other member states. So I suppose it's in a privileged position where it can be in and out of the UK system to a certain extent, which, you know, we're in a different situation as being one of the EU 27 member states.
And in terms of this, why we chose to pair up with Scandinavians as opposed to the future, what was that based on? Is it just that they were easier to talk to, or are we more aligned with them in terms of our formulations? Or
you know, to be honest with you, historically countries have had alliances. Not surprising, the Benelux countries have kind of arrangements. The Scandinavian countries have arrangements. I mean, we've opened up to discussions with other colleagues among the European network and those possibilities, but I suppose the Scandinavian discussion is the one that's today probably advanced most. That's not to say there aren't other possibilities there as well too. I think Rita wanted to just make a point on the UK situation as well.
Well, in relation to inspection, most big UK pharmaceutical companies are exporting to the EU, and therefore they must comply, no matter that they're based in the UK, they must comply with EU law, and they are subject to EU inspections. Now, whether there'll be resources is a second issue, but there's a huge, well, it's not even an incentive to stay aligned. They certainly must stay aligned if they want to continue access to the EU.
Thank you.
Thank you very much, Deputy O'Connell. So I think that concludes our hearing this morning. Thank you very much for coming in. On behalf of the HSE, Miss Paula Keown, Mr Hennessy and Mr Swords, and on behalf of the department, Mr Breslin, Mr Smith and Fergal Goodman. And thank you, Dr Lorraine Nolan, Rita Purcell and Dr Katrina Fisher. This meeting now stands adjourned until next Wednesday morning, when we will engage again with the Department of Health and the HSE on general matters. Thank you very much. Is that agreed? Agreed.